A very good afternoon to everyone. Um, we're going to start in less than 2 minutes. We're just trying to sort out some technical issues. We're giving a chance, but otherwise we continue with the session. Give us only 2 minutes.
Okay. It will take more than a couple of minutes to sort it out.
All right.
So I say start.
Okay.
And then
Cool.
we will continue.
Thanks. Good afternoon again. I think we're going to start while they're trying to sort out the technical issues. So we have someone who is online, but we also have our panelists who are already in the room. My name is Cedric Ninahazwe. I work for the Global Network of People Living HIV as a Global Advocacy Manager. I'm going to co-chair this session with Brice Bambara. He's gonna help me navigating throughout the session, but also supporting the interaction between the panelists and all of you. So once again, thank you for joining us. I think you made the right choice. Let's talk about financing. It's very important. With me, I have on my right Nathaniel. I'll give you 30 seconds to introduce yourself so that I don't make any mistake.
Good afternoon, everybody. My name is Nathaniel. I'm a program officer at the Robert Carr Fund based in Amsterdam.
Good morning, good afternoon, actually. My name is Rosemary Mboru. I am the executive director for Waki Health. Waki Health is an Africa regional advocacy organization. We are a convening organization, including networks like the Africa Free of New HIV Infections, AFNI, the Global Fund Advocates Network, and we are happy to be here. Thank you.
Thank you so much. We have another colleague from UNAIDS, Jaime, Equity Financing Director. So he could not be here, but also he's trying to be online. And we kind of knew it's going to be a little bit hard to get people who are attending from online. Then he quickly recorded a video, but he will be behind the scenes so that he can interact with us when the moment comes. It's going to also help us to keep us time. So without further ado, I want to start with the first speaker. But for you to know why are we here, I think the room already tells the reason. Financing, HIV financing is important for the AIDS response, but we know that financing health is one of the other priorities that the world is facing at the moment. We've seen a decline or maybe difficulties to get funding in some sectors, especially in HIV response. It used to be not the case, but this is the reality we are evolving now. So instead of for us just sit down and wait to see what is happening, it's better we also discuss these things and get some kind of strategies, but ideas. How do we move forward? How do we optimize the funding we have to reach the target on 2030? That is why we are here. That is the main purpose of this session. So as I promised, without further ado, I'm gonna ask our tech team to display Jaime's presentation. He's gonna introduce himself again in the video. But again, Jaime is the Director of Equity Financing at UNAIDS. Tech, please go ahead.
Good morning, good afternoon, colleagues, and thank you, Cedric, for the session and for the invitation. I'm so sorry I cannot be with you in Harare today, but this seems to be the best possible option, sending you my video recording to avoid any potential IT glitches. My presentation this morning is really answering to a question: what is the situation around HIV financing that relates very much with health financing, and what are the challenges and what are the opportunities? So that's what I'm going to speak about today. And as you know, UNAIDS has been collecting the data and processing the data, especially on domestic financing and international financing, to offer everyone a full picture. So let me share with you my screen. And here you can see, I'm going to move it from my own. I'm going to share with you an overview of HIV and health financing trends in Africa, talk about the challenges and talk about the opportunities ahead of us. The first thing is just to reiterate that we have a widening gap. As you see with these bars speak to the global HIV response. Our aspirations for 2025 to fulfill the targets and the objectives of the political declaration are 8 billion under the resources needed. When we look at the resources that are coming from the two main sources, let's look first at the international donors. They are not the largest, but they are very relevant, especially in Africa, especially for low and low middle income countries. We can see that it's been up to 8.3 billion of annual international development assistance. And that means a 3% decrease in international resources. And it's a 17% decrease from the peak levels of their response that were coming in 2013. If we look on the other side at the domestic funding, the domestic resources that has been the main driver of the growth of HIV financing and the capacity of countries to deliver on the HIV response has also stagnated and is declining, has been declining over the last 3 years, around at 2% per year. So we're seeing that it stagnates and then it starts to decline a little bit, and that's about HIV financing. Let's look at some other dimensions that are of particular interest to us in this room today. The first thing is to say that funding for HIV prevention among key populations is taking very small proportions of total HIV spending. And here we see the comparison in the blue bars against the resource needed if we want to ensure that we are putting enough against prevention among key populations. You can see the proportion is really low, and even where this is highest in Asia and the Pacific, it's under 10% where we are looking at the needs that go above 20, 25, 30, or 35%. When we look at the whole low and middle income countries group, while we would need a 20% investment, we are roughly on 3%. And let's look also at the price reductions in antiretroviral medicines. As you all well know, the bill of medicines is 30 to 40% roughly in most of the countries. So the price of these medicines is critical for the sustainability of the HIV response and for the cost of the HIV response. Here you can see that while in some countries we have seen significant reduced prices, especially when we look at Eastern Europe and Central Asia, Eastern and Southern and Latin America, the prices are still very high. They are low, and they are the lowest in Eastern and Southern Africa, as well as Western and Central Africa. But probably even at that low, we need to push for them to go lower, especially with the new products that can be introduced. And let me share now a screen, broaden the scope and look at health financing. And these are the projections of our colleagues from the World Bank. As you know, World Bank is one of UNAIDS co-sponsors. What we see here is that only 1/3 of the countries in green, would be expanding their investment in health per capita, as a percentage in the coming years until 2026. This compares the 2019 pre-COVID to 2026 spending prospects. And what we see is that even those that grow only grow 2.3%. So a very low growth when we have seen growing needs. But the worst part is that we see 2/3 of the countries roughly that are either contracting, so spending less, or projected to spend less if the current trends of growth, tax collection, and health spending stay, and or stagnating, so roughly remaining the same average with less than a 1% increase. And let's go also, let me share this slide I like very much. It's from our colleagues from the Global Fund, and I like very much the way they project these four trends. Rising debt distress. Today we have 23 out of 40 African low and low middle income countries that are in that situation. Debt distress or high risk of being so. Surging food insecurity and prices. This has um, softened a little bit, but not that much. We are still in that trend. Revisions of expected growth. Growth is lower than expected, and that means that there is a reduction in government spending because we are not collecting more taxes. So that's the bleak picture we are up against. So all the proposals, all the opportunities I'm going to mention now are happening in this very difficult context. Let me very schematically share with you that when we look at how to finance the HIV response, we can look at domestic. So to change or to increase the domestic resources, we need to grow the revenues overall. That's the most safe option. To increase the allocation to health, so to earmark it or secure it. And I think those are, and to introduce new figures such as health taxations, health taxes instruments. That's our first and our top option, I would say. Then we have donors when there has been a bilateral decline, and we need to look at going beyond Global Fund and the US, that is the largest donor, and look at other donors and look at non-DAC development actors, because they also play a role and could play a growing role into the future. And there is a third bucket that includes debt relief, development finance institutions and development banks instruments that could be used for health and for pandemics and HIV. The IMF special drawing rights, that's the currency of the IMF. There was an issuance of this currency. We are proposing together with many that there is a new issuance focused only on developing countries, because the previous one was only, so to give you just an example, 5% of that issuance went to the Africa region. We also have opportunities in blended instruments and public-private partnerships and private instruments. So we have three buckets, and we need to look for the new opportunities are in the third bucket, but domestic and donors are still relevant, and we need to make sure that there is action and pressure on all. And I will just summarize here what are the main opportunities. Well, the first thing I want to mention is the relevance of investing in redefining sustainability. The second one, and here we need to enhance country leadership, reassess the status of HIV, and establish the needed transformations and goals. And UNAIDS, together with PEPFAR, together with other partners under country leadership, is pushing to readdress sustainability in a new way, where we cut it to the bone and we look at the main transformations of what the cost would be and what the main investments and the most impactful would be. The second one is the tax reform agenda and the fight against illicit financial flows. So we have Africa losing to illicit financial flows every year, 88 billion according to UNCTAD. So we need to strengthen tax administrations, and we need to cut exemptions that allow for tax dodging for individuals and companies, so that those illicit financial flows stay in the budgets and can be deployed to different priorities, including health and HIV. And as part of the tax reform agenda, we also have health taxation, ensuring that multinational companies especially are paying at the country level what they, according to their economic activity. Third, we have debt relief and rechanneling the fiscal space created to health and HIV. As I mentioned, we have too many countries in debt distress requiring a solution, an urgent solution. This is now a protracted crisis, as countries are paying today 3 times more on average in Africa to debt services than they are spending in health. That's one of the main needs of their population. And this requires a response, and that response will generate fresh resources when it comes. We need to be ready to make effective investments in health, HIV, and pandemic. And finally, we need to look at these other sources of financing deployed to health, pandemics, and HIV. I already mentioned those sources, so I want to leave it there. There are other alternatives. These are part of the third bucket I mentioned. And this is just my last slide. I wanted to mention other factors that are part of the sustainability approach and of the needed options into the future. And I think these four headlines are the ones I want to mention. Moving towards an integrated health service model is going to generate cost-effective approach. Integrating HIV services into national health financing to boost the sustainability of the response, engaging in public-private partnership, and most important, sustaining community-led response to HIV as a means to deliver best and to deliver last-mile services in prevention, testing, and treatment, and reach underserved communities. This menu of changes and options is what we want to further when we talk about how to better finance the HIV response and how to improve and make it more sustainable. I want to stop here, colleagues, and hand it back to you in Harare. Thanking you very much for your attention and for your kind invitation, and again, apologizing for not being there with you in person. Over.
Thank you so much, Jaime. Jaime has also managed to, I think he's online. You can just give us a sign if you can hear us. I mentioned in the beginning that you made the right choice to join this session, and I'm going to make it practical. We have two other speakers, but if you have a question after this presentation, please let us know, and then we try to give you the support. We don't want only for you to listen to speakers, but it's also important that we make this a conversation and maybe get more from our panelists. So if you have a question, you just have to raise your hand. It's the only thing that we ask you to do. In the meantime, I think we all know there's that challenges, the opportunities, but people, including myself, we're like, there's money somewhere. We are all sitting here. People are flying to ICASA. There's money, but where is it coming from? But also the other question is, what are we doing to prioritize the less resources we have to make sure that we are getting where we want to go? That's the question. And then I've seen Rosemary, Waki Health, and other civil society colleagues supporting the Global Fund, for instance, for the replenishment of civil society. And my question is, how do we, as we support the replenishment, how do we engage in prioritizing? How far do you see we are in terms of making, deciding what is a priority to optimize the resources we have?
Thank you so much, Cedric. And agree with you, there is money. What we don't have is enough political will to invest in the priorities, but also to invest in letting communities lead. There's no political will. So we have the policy, we have, from a political point of view, the slogan, the statements, but no political will. And I start there because a few of you in this room might know, and I'm coming with so many mixed feelings and really still trying to organize my thoughts around this. And I was saying to Breeze, I'm so sad. So many of you might already know that the People's March has been canceled. We know, and we know as communities and civil society, we have had a very rough start of the ICASA. And so this question that my friend and colleague Cedric is asking me about civil society and communities engaging in setting priorities, I feel like I want to ask a question instead of responding. How will communities and civil society participate in setting the agenda, in setting the priorities, in resource mobilization if civil society cannot lead? And I think the question is, if the space and the environment is not conducive, if people have to live in fear, if people don't feel safe, how can we actually then participate in the presentation was talking about communities and civil society as participants in the sustainability agenda for health financing, talking about community-led responses as one of the key drivers to meeting the last mile in terms of service delivery for prevention, for treatment. But the question we have today is, but how will we do that? How can we even be part of this conversation if in a space like this where we are, communities and civil society don't actually feel like it's a space that is we would have wanted it to be in terms of engaging, expressing, etc., etc. And I want to also say, we understand the guidelines, we understand everything, but how do we ensure that there is an environment, a space for communities to engage? So that's the first issue I wanted to raise, that yes, there is money, and we see our governments are choosing to invest that money in so many different places. But you know what? No amount of advocacy and political documents and technical reports will actually get us to the last mile if communities and civil society are not part of that. So it is also about investing in that freedom, in that ability to engage in the space. In terms of then, how do we ensure that we are part of the conversation, setting priorities, including in resource mobilization? I think there are a number of opportunities. One of them you have mentioned, Cedric, is the Global Fund replenishment. Let us remember, first of all, that we are coming from the 7th replenishment and we did not meet the target. We are now starting conversations around the 8th replenishment. The world is a tougher place, I would think, than it was when we were working on the 7th replenishment. We are seeing the polycrisis of climate change, pandemics, food security, and rising prices, and so on and so forth. So I think we agree that the landscape is much more challenging now in terms of us raising the funding. And I can tell you that to even meet the target, the amount of money that we raise, like through the Global Fund replenishment, it takes a lot of work by communities and civil society. That money doesn't just happen. It's a lot of work by communities and civil society at the country level, at the regional level, at the global level, really a coordinated approach. And so, that is an area where we are engaged. But I also want us to ask ourselves, as we move towards that opportunity, how are we leveraging on community leadership? Because community leadership, for us to activate that, we really need to ensure that it's not just a slogan, but it is actually supported, it's funded, etc. Allow me to talk about the PEPFAR reauthorization again, as an opportunity in terms of the money that comes to the country level that supports with this. And we see the danger when we really have to push for certain things and to really ensure that the political will is there. The risk is huge if some of these processes are things we have to renegotiate, we have to re-educate, we have to really talk about what it means to saving lives. So I think that's another area where communities and civil society, come in terms of bringing the evidence of the impact of these investments at personal level, at community level, at country level. So I think that's also, if we think about external funding, and I know there are many other sources, including bilateral conversations in terms of money. I think the thing with bilateral, if I may just mention, is for us to then, push and engage, because not all bilateral partners think about community leadership, think about societal enablers, think about all the things that we think about here. And so how do we ensure that that is at the center? And the thing around domestic resource mobilization, it has been mentioned. We are off the targets. We have regional and national frameworks. In Africa, we are mostly guided by the Africa Leadership Meeting on Investing in Health, the ALM, which is the health financing framework that African Union member states have endorsed. It's a declaration and it has targets, including national budgets, 15% of national budgets going to health, 5% of our GDP going to health, and then incorporating the other targets like 86 per capita. But also one of our biggest challenges is the out-of-pocket, costs here in Africa. And I know whether it's HIV, whether it's TB, whether it's malaria, there is so much out of pocket here and there. And so how do we ensure that according to the ALM declaration, we are pushing for the right political will to meet, because the declaration commits member states to lower their out of pocket to below 20%. The average of out of pocket in our region is like 40% out of pocket. So basically, people are funding health systems from their pockets, and that's pushing us further into poverty. So those are really quick reflections. The last one is within domestic resource mobilization. There is the conversation that has been going on around social contracting, basically where you have public investments being allocated to like civil society community groups. And it takes back to my first question. If the environment is not enabling for certain communities, if the environment does not even recognize certain communities, how do we have the conversation of domestic resource mobilization from a social contracting point of view? If you think about community-led responses, if the environment is not even in the first place supportive of certain communities. So let me leave it there and really open for additional, messages or comments. Thank you.
Thanks very much, Rosemary. As I mentioned in the beginning, we're still open for questions, so don't wait for speakers to. I've noticed two, I guess, so I'm gonna come very shortly for the question. Social contracting, but most importantly, I think we have a precondition. The environment in which the community and civil society are operating is very important for us to set priorities. There's a triple dividend report that was published by UNAIDS, and it does mention that 57% of the funding at country level is coming from external funders. Aside, we do have funding that comes from Robert Carr as well, supporting networks and communities to actually do the work without necessarily having to really, have a key, I would say, without a condition to finance, you finance more co-funding, which is really useful to support other funding. So I want to ask the Robert Cat Fund. I think we are operating in the same system, in the same environment, the kind of funding. What do we need to make a case for a new replenishment for Robert Card? I think it's really important for networks to understand what do we need to do, because we still need those funding, and we know that you probably need our help, but what do you need?
Yeah, so what do we need to sustain funding? Thank you, Cedric, for inviting me to be here. First of all, let me just begin by framing who we are as the Robert Carr Fund. So we are a pooled fund that was established in 2012, and was named after Dr. Robert Carr, who was a Jamaican activist. We are a pooled fund of UK, US, Norway, the Netherlands government funding, as well as Bill and Melinda Gates Foundation. And in 10 years, we provided $120 million to community-led networks and consortiums of community-led networks. We are a participatory grant maker. What we do is we have community civil society members on our board, equal number to donors. We have a program advisory panel whose representative and found from the community. The civil society members on the steering committee are the ones who make those decisions of program advisory panel members. And we listen and we learn to the grantees that we fund, but also to the communities that they serve, because the work goes beyond just the grantees that are doing this work. We provide long-term 3-year flexible core funding for these grantees. They are able to decide how they allocate the funding. So the current position we see in the 3-year funding cycle that we're in, we have 24 grants, and that's 72 organizations globally and regionally. Out of that, 17 we can say could be considered financially secure for the next 2 years for their strategic plan. So there's a huge gap there. It's 24% out of 72 organizations. The other sources that they find generally are activity funding or short-term funding, but not core funding. And we see that community-led networks need funding that is flexible, that they can design for themselves where they apply that funding, how they use it, to be addressing the needs of the communities that they serve. And advocacy for more and better funding is highly technical and requires expert staff and experienced community leadership. But you can only do that with core funding. The costs of training and retaining staff in the area of resource mobilization and accountability is key for community-led networks to find more funding for themselves, and also to support people like us as the Robert Carr Fund to secure more funding. So for community-led networks to sustain funding, they also need to demonstrate the need. So they need to go back and do community-led monitoring, community-led research, and engagement with communities. They need to be participatory as well. So we're trying to make sure that we're all participatory at all levels, communities are engaged at all levels. And that community-led monitoring and that research and the data that these networks develop needs to go back into, we believe as a fund, needs to go back into strategic plans of these organizations, which are costed, and have a resource mobilization strategy plan. Where are these funds coming from? How are you going to advocate for more funding? And they are the tools that we can use as a fund, that data, to then advocate at government level for more funding to come forward. And these networks, they're all doing this work, and they need to link up and align and learn from each other, not duplicate. There's strength in numbers. We're all advocating for the same goals, the end of AIDS or HIV by the 2030, these targets, but it also has to go beyond that because it won't end by 2030. We need to be, these environments will not change by 2030, and we need to keep pushing beyond 2030. The goal and the target of 2030 is great. We keep going towards it, but we need more, and we need to keep going forward, and we need to strategically cost that out as a community, as a group of people. And any resources that come to these networks, we feel as a fund should be flexible, should be free of donor requirements. We provide funding that's free of donor requirements. And the data and the activity funds that the grantees do is for them. It's not for our benefit, it's for them, it's for the communities. And that includes decriminalization across the continent. If we aim to achieve the 2030 targets, that money needs to also go towards decriminalization. But also the us is not only the networks who are doing this work. It's also us as funders and as donors. We have a responsibility as well. And the Robert Carr Fund, we have this participatory grant model. It changes, it develops, it learns from the communities that we work with. And it's a model that we can demonstrate that is effective and responsive in community-led networks, supporting their needs and supports their impact that they have. Further, I think donors need to be responsible for the funds that they have access to And we need to minimize the amount that stays at secretariat level and goes to the communities and to the networks as well. And I would say to other donors and funders in the room, link up with us at the Robert Carr Fund and join us to explore ways how we can make funding more participatory, that it gets down to communities and that communities decide to help us shift the power to community-led networks to achieving these targets. And then in summary, so I would say for networks, align, strategize, cost those strategies, and resource mobilization strategies. Where are you going to target your strategies at to get your money for your goals? Community-led monitoring. And for donors, I would say fund flexibly, participatory grant making, link up with us at the Robert Carr Fund, and let communities decide how funding is allocated, core funding.
Thanks very much, Nat. I got the hint. I hope everyone also got it. But we have a few minutes before the end of the session, and we have 2 questions already. I'm going to ask Chris to help with the mic. So where's the mic? The roving mic? Okay, it's there. And we have Jaime online. Hi, Jaime. Check
Hello,
sound.
colleagues. Can you hear me?
Yes.
Great. I've managed to see the whole session, so that's good.
Thank you. My name is Anotida. I am from Namibia. I am a GP and a health economist. And I want to maybe ask and also make a suggestion. First, about funding. Where does most of our spending go to in terms of HIV management? Maybe drugs. And as Africa, we are like a household that is spending billions on buying bread, actually asking for money to buy bread, billions, and not building a bakery. And that also impacts on our spending. We cannot always ask for money to buy drugs when we can use those resources to manufacture our own drugs here. Most of the drugs that we use for first and second line are not on patent anymore. If we do that, we save a lot of money. And the other issue is moving resources from programs which are not as impactful anymore. Now, take, for example, VMMC. How many circumcisions do we now need to do to prevent one infection in line that we are treating everyone? And most countries are reaching 95, 95, 95. Move that money. And also integrate programs, share costs. Most countries are moving towards national health insurances now. Why don't we integrate all the programs together? Make that money go maybe towards efficient systems, health systems. That will help. Instead of just saying this is budget for malaria and this is budget for TB, this is budget for HIV, combine them, let them share costs. The total cost will be less than costing them as individuals. We can do that. Let's not blame politicians. They also need to be led by science and facts to say, if we do it this way, the politicians will save so much, then it will help. Thank you.
Thank you. Thank you to the.
Can I ask you maybe to use like 1 minute maximum? Sorry, we're running out of time. Not pressure, but try.
1 minute is too much for me. Thank you very much for the presentation, and also thank you for the discussions that we have had. And I agree. My brothers already talked about efficiencies that for me still remain a key. Efficiencies still remain a key for me in terms of the way that we implement our activities. But I think the question that I really want to ask, it's on the presentation that we have just had in terms of debt relief. I just want to check in whether we have basically navigated this area and we have seen the possibilities of actually obtaining debt relief, so that countries then, do not keep on hearing about pursuing debt relief if debt relief is not possible. So I just need to find out whether we have had strategies within UNAIDS and the global partners where we have pursued possibilities of debt relief, and how can countries attain those, etc., etc. Thank you.
I'm gonna take two more questions. This one, and there's the one in the back there. Then please go ahead.
Thank you so much. My name is Angelo. I'm from EVAC. I just wanted to make a quick comment about my colleague's submission about efficiencies. I totally agree. We should be more efficient in our programming, but we also should not set ourselves up to pitch one intervention against another. We need options. We need choices. We need to ensure that there is oral PrEP, there is the proven ring, there is CAP4 PrEP, there is VMMC for the different populations that need them. We definitely need to do better to be more efficient with the way we use the resources, but pitching an intervention against another. And VMMC, for example, most men, their interface with the healthcare system is through this intervention. We're seeing a lot of benefits for people who come in to get VMMC. So I just wanted to make that tweak to his submission to say, let's roll out the interventions that communities need and meet them where they are. Thank you so much.
Thanks. We have another question in the back, but I just want to make sure that Jaime, I don't know if you got the question, especially on the debt relief. If you could start thinking about that while we get the question in the back. And then we also give an opportunity for our speakers to react on these questions.
Yes, thank you. This is Sabino from Mozambique. I work for an LGBTIQ organization, and I appreciate all of the 2 or 3 presentations that we had, and I want to sign underneath of what has been said. But I just wanted to let quickly 3 notes, the first of which has to do with the reduction of funding for intermediate organization. I think this is one of the things that we've been discussing in the civic space in Mozambique, and it's worthwhile considering. And then advocacy to push for the government so that the private sector can allocate a percentage amount of their revenues to the civic, organization from the civic space, civil society. And finally, one thing that I think that was not mentioned has to deal with building capacity. Because what happens is that the big organizations come, they do their things, they have their own objectives and goals. And when they leave, they don't leave any capacity. And we are challenged sometimes because when we don't have capacity to compete in this aggressive specific space, and then things just become very complicated for civil society organizations, especially CBOs, to compete in equal level. Thank you.
Thank you so much, Jaime. I hope you note the questions, and then but I will give you only 2 minutes, and also for other speakers, if you can do less than 2 minutes, that will also be great, please. Jaime.
Thank you, Cedric. I hope you can hear me. Let me right away answer some questions. First, social contracting has been mentioned. We are pushing for social contracting to be a modality that increases in its presence and strength across countries. Community instruments need to be institutionalized to be a pillar of future-looking sustainability. So that's my reaction to the whole community and social contracting points made. We need joint efforts for stronger sustainability, and we need the voices of community organizations, civil society, together with governments and other actors, as well as regional partners such as NEPAD there in the room. We also need to make sure that we can make the case of what is needed to end AIDS and what can the response to AIDS contribute to other objectives, be those health objectives or be those social objectives that come up. And in our report, Triple Dividend, that was mentioned, we talked about this. Finally, integration into health systems and including HIV response into the new mechanisms being developed is essential, and we need sufficient financing, but it may be more sophisticated. It's not just a funding taking funding as money moving from one place to the other, but financing instruments so that we can get into additional resources and new streams of finance. And finally, the question about debt relief that was made, we have only seen 3 countries achieve or get close to debt relief after a long period, but the fact that the list of countries is growing bigger and bigger and the troubles are not going away but increasing is the proof that we are going to need a response. We've heard it in several annual and spring meetings of World Bank and IMF, and UNAIDS is joining the voices calling for those debt restructuring mechanisms that are possible and that will come forward at some point. If we make the case that is a solid way of responding to crisis, to invest in health, in HIV and pandemics, we will be able to redirect some of the resources in that new additional fiscal space, together with the additional instruments I have mentioned. And I'm going to leave it there, Cedric, so that my colleagues can speak and respond. Over.
Thanks so much, Jaime. Thanks so much. I really appreciate. Can I start with Nat and then go to Rosemary?
Yeah, so to begin with, on this side of the room, I agree with the 3 gentlemen here that, sharing costs and reviewing programs that are currently being funded and they're not efficient, they're not doing what they need to be doing. Why do we keep doing them? And again, I think that goes back to the funder themselves. If they have a goal or they want data from community-led networks,